And there are essentially 3 or 4 admitted flow streams. There's ambulatory emergency care, stroke, short stay. There's sick mono-organ specialty. There's acute frailty, and then there's the hypercomplex, people who normally need to go straight to ITU, either the polytraumas or the multi-organ failures. I'm not going to talk about those rare strangers today. I'm just going to talk about the first three groups. If we just go on to the next slide, please. And it's very clear about how you need to maximise their management. And they need to be managed by expert teams as close to time zero as possible. Not the next day, as close to time zero as possible. Because if you don't start the case management plan for the admitted patients effectively as close to time zero as possible, and you waste the first day, you just keep on adding to that length of stay. So for frailty, for instance, my area of expertise clinically, how many people here know what rate you can lose quadriceps power generation, not strength, in the first 12 hours of a hospital admission? You can lose 5% of quadriceps power generation in the first 12 hours. My research is in muscle physiology. If you lose 5% of your quadriceps power generation and you're frail, you can be converted from somebody who's just about mobile to being requiring 2 to transfer. And if that happens, you then got a long length of stay. Guess when you lose most of your functional reserve when you're in hospital? Is it because of the acute illness? It is if it's catastrophic, but the vast majority of frail older people actually are admitted with mild to moderate acute illness. It's the hospitalisation that causes the decompensation, that causes huge extension of length of stay.